Okay, I think we're ready to go. We're just at 2 past the hour right now. So good morning and, in fact, good afternoon, as I know we're spanning multiple time zones. I'm Ed Tuchon, Director of Business Development with Regent Revenue Cycle Management based in Chicago. Welcome to the first of 3 segments devoted to benchmarking exclusively in the ASC community. Before we jump into today's topic focused on optimal ASC business office staffing, I'd like to provide a quick introduction to both the organization behind today's study as well as the study itself. Regent Revenue Cycle Management is an independent division of Regent Surgical Health, a veteran ASC management and development company with 15 years in the ASC industry. Back in 2005, Regent Revenue Cycle was launched as a central billing office supporting Regent centers, and in 2014, Regent Revenue Cycle expanded its services to the entire ASC community, maintaining an exclusive focus on ASCs. As part of the Revenue Cycle team's ongoing focus on efficiency and workflow, the Business Office Staffing Metric Study was born back in 2010 and actually continues to this day. At a high level, the study encompasses 5 years of ASC data compiled across 18 centers here in the U.S. Importantly, the study takes a holistic approach in understanding optimal staffing, looking not just at the numbers, but at 3 key factors that have direct impact on staffing itself. One quick housekeeping item, if I can, and I promise I will be quiet. We originally intended to host the webinar as an open mic event. However, given 62 participants logged as of this morning, we've decided to keep the mute button on and avoid any background noise. That being said, importantly, we welcome your questions throughout the course of the presentation. You can submit them through the WebEx Q&A functionality, or at the end, we'll open up the mic and we'll have a full audio portion attached. At this point in time, I'd like to hand the mic over to Mike Orsino, today's host. Mike is the Vice President of Regent RCM and, in fact, the originator and ongoing owner of this Business Office Staffing Metric Study. Mike?
Thank you, Ed, and thank you to all of you who took some time out of your precious days to join us in a discussion on an important revenue cycle benchmark. Again, our sincerest apologies to those of you who I communicated to on the Ask a listserv that this would be an open mic session, but as Ed said, just due to the overwhelming number of people, we thought it would be more efficient to go through the entire presentation and then take questions or comments at the end. So that being said, wanted to give you a little bit of background on the reason we decided to perform this webinar. And it's really in response to an initial question that was posed on that listserv through ASCA, questioning about the optimal number of business office staff for the ambulatory surgery center. And it's a question that's asked often, and to be quite honest, when I joined Regent in 2010, a little over 6 years ago, it was a question that I was asking because my background was, although it was in revenue cycle, was in practice management, not necessarily ASC. So it was a question that I was asking, and as we ramped up new centers within Regent, we were looking to staff our business offices appropriately. So we will get into the background of that particular metric. But before we even go to that metric, we thought it would be important, and one of the reasons we're having this webinar is we didn't feel like just putting out the optimal number would do justice to any of you, because a number such as 1.5, which I've seen floated around quite a bit, business office staff per 1,000 cases, while optimal in some situations, it may not be optimal in your situation. So it all is affected by case mix, payer mix, number of ORs, so a lot of different factors go into this. But before even addressing this metric, as Ed alluded to earlier, we need to look at 3 different questions that you must consider really prior to addressing your business staff ratio. So the three questions that you should definitely consider prior to addressing your business office staff ratio. The first one is, do we have the appropriate staff in place? Second, are policies and procedures implemented to promote revenue cycle productivity? And third, are you utilizing advanced technology which will drive efficiency in the business office? So I'd like to take a few moments to address each one of these questions individually, and then we'll get into the meat of the discussion, which is the metric itself. Staff experience. So from our perspective, and I'll speak from what we have here at Regent, we have about 26 different facilities. And what you see is we have front office personnel in our facilities that have a minimum of 2 to 3 years of ASC business office experience. And this is different from how it was 5–10 years ago, when you'd have your lower skilled employees, maybe those making minimum wage, up working the front desk. The trend now in what we recommend is having more experienced people up at the front desk, because as patients have higher deductibles owed and much more of the burden is being pushed on the patient, it's imperative that you make arrangements for or collect prior to or at the time of service. And traditionally, the lower skilled workers, that's a job or probably an assignment more suited to someone who can figure out what the out-of-pocket expense will be. So you want to dedicate more of your higher skilled personnel to the front office as well. Obviously, your back office personnel, you want your more skilled personnel back there, and what we're finding is, we want to have the 8 to 10 years of revenue cycle experience, preferably in an ASC setting, to provide those back office functions. And those are your billing, charge entry, your payment posting, your payer follow-up, and your patient follow-up. Also, you want to make sure that you have clearly defined roles and responsibilities for your staff. For instance, are your staff cross-trained? Are they able to assume one member of your staff, if they go out on maternity leave or they have long-term illness, is another member of your staff easily able to pick up where that person left off, so we don't have a decrease in cash flow or an interruption in cash flow? And finally, do your staff have bilingual capabilities? And this is particularly important if you live in a community, in which of us don't live in communities that are multicultural. So if you have a high Spanish-speaking population, it'd be a good idea to have someone on staff that's able to speak that Spanish language, and same goes for Polish or any other language. So know your community, and like I said, if you have a high number of bilingual population, you probably want to reflect that in your business office. Next, the policy and procedures. Do we have policies in place to promote your productivity? So one, you want to make sure you have effective processes in place. For example, is there a process in place that will handle exactly what happens when a payer submits a denial or a zero pay? What are the next steps that the payment poster or that business office staff personnel have to do to appeal that claim? Another process to consider is how often are your business office staff touching or working your receivable accounts? Our standard here is that our staff are to work every account on their AR at least once every 30 days, twice for accounts greater than 90 days. Another process to consider is, are your staff posting payments by line item? You see oftentimes where payers will pay in one bulk payment. It's up to the payment poster not to be lazy and to post each of the, to determine how much of each different CPT code was paid, and to allocate that by line item. So that'll allow them at the time of posting to know how much if the claim was paid correctly, and two, when you're auditing in the future, to be able to determine much more easily whether the claim was paid correctly. Another process, are you performing patient financial counseling? Again, I touched upon it earlier. This is a critical role to play on the front end to make sure that not only have the benefits been verified, but that you've verified with the patient what insurance they currently have and how much they're going to owe out of pocket, and possibly collecting or arranging for that payment up front. Second, you want to make sure you have efficient workflow. And some management information systems dedicated to the ASC industry, you're able to set up tasks automatically in the MIS, which should promote an efficient workflow. So that's number two. Number three, you want to make sure you have recurring audit cycles and cycles that really drive the continuous improvement. Here at Regent, we conduct quarterly reimbursement audits, so our supervisors, for the staff that they supervise, they conduct every quarter audits to make sure that we're being reimbursed properly and that we're collecting every dollar we're contractually obligated to. Second, we also conduct biannual business office audits. We conduct audits twice a year, and we're not just looking for, reimbursement, we're looking at the whole continuum of the revenue cycle. So from the very beginning, from patient registration, where they register correctly, scheduling, insurance verification, all the way through to the back office functions where they're billed properly, we're looking at whether or not the payment was posted properly, follow-up conducted properly, all the way through to zero balance. We also oversee coding audits. So we want to make sure that we stay in compliance and that all the cases were coded properly. Again, making sure we're doing that twice a year just to make sure that we stay in compliance, and this is done by a third-party audit company. One point I wanted to make that on the second bullet point on the efficient workflow is we want to decide on the workflow piece whether you're separating staff by function or are your staff do all the functions all-inclusive. What do I mean by function? Function is meaning payment posting, billing, follow-up. So do you have a bunch of collectors or people that do collections, some people that do billing, or do you have one or two people that do the whole gamut of billing, payment posting, and collections? If you have it separated by function, how do you manage the workflow? For example, for the payment poster and the handoff to the person doing follow-up. If the payment poster is not posting payments in a timely manner, you'll have the person doing follow-up tripping over that person because they may be trying to follow up an account that's already been paid but just not reflected in the system. Here at Regent, our staff are all cross-trained and do all-inclusive, so we don't have payment posters and collectors and billers. We have each of the revenue cycle specialists we have do the gamut of billing, payment posting, and follow-up. And finally, are you utilizing advanced technology which drives efficiency? First is you want to make sure you have an advanced ASC Management Information System, or MIS, and it's very important that it's specific to the ASC industry. We find often that facilities try to use a practice management software or perhaps the hospital billing software, where we've seen in several instances. And this is really trying to put the proverbial square peg into the round hole. And sure, of course, after some time you can probably get that square peg to fit through that round hole through a lot of work and effort, but really, why go through that hard work and effort to get that peg through that round hole when you could just buy the round peg to begin with? So it's important to have a system that focuses exclusively on the ASC industry. Some of the abilities of the MIS that you're able to do in these platforms, you're able to upload your contracts into the system, which will allow that payment poster to know exactly how much we should be getting paid at the time of posting. should also have a document management system that will allow staff to be able to scan documents into the system, and not only at the system but at the chart level. So much easier to find and locate documents in a much more efficient manner. And finally, as I mentioned before, some of the MISs have a workflow function. And so within the workflow function, there's individual tasks that you can set up that will manage your workflow. Examples of these tasks include insurance verification, patient collection, insurance collections. So for example, just to give you an idea of how this workflow and the task works is the administrator, the supervisor, or the business office manager is the one who sets up the task. And you can assign the tasks by individual user. So if you have Sally and she does insurance verification, you assign all insurance verification tasks to Sally. Or let's say you have more than one person who does collections. Let's say they do it alphabetical. You can assign the collection task to both of the users, and each of the users can access each of their coworkers' task log. So there's never that kind of separation. And then it's much easier if you're doing, as a manager or an administrator, if you're performing audits or you want to make sure that your staff are following or working about 20 accounts per day or so many accounts per week, you can run reports based on this workflow to much more easily manage that staff productivity. Second bullet, want to make sure you have a robust clearinghouse used to handling claim volume for ASCs. Again, some of the clearinghouses of today go beyond just the electronic billing and receiving of electronic remittance. They have the ability to conduct real-time eligibility. And so gone are the days where we're calling the payers or going out to the payer's website. With one click of the button through the management information system, you're able to not only determine the eligibility, but pull all that data right back into the MIS at the chart level. So less than a second, you can get not only are they eligible for this procedure, but what are their in-network benefits, what are their out-of-network benefits, how much of the deductible has been met out of the total, all those statistics you can get at a moment's notice. So that really will drive efficiency in your facility. You also can set up custom claim edits in the clearinghouses of today. So instead of waiting for a claim to be denied 30 days, 60 days, and go through that process, if you know a particular payer, if you notice a denial pattern where a particular payer is denying a particular code, you can set up these specific edits within the clearinghouse so they reject right when you try to bill out the claim so that they can be fixed within 24 hours instead of, again, waiting for that 30 to 60 days. And finally, you want to use, or if you can, utilize a reporting analytics or real-time dashboard capabilities or software that can perform these. Admittedly, how advanced the MISs are of today, I think they would tell you that they have reporting, but they're not as advanced as they could be, and I think that's done on purpose. I mean, the MISs want to focus in on what they do right, and that's the scheduling, the inventory, the insurance verification, those core pieces. That reporting that they'll offer is somewhat robust, but not robust enough to really do, to produce, for example, customized ad hoc reports. So if you have a physician that comes to you and says, I want to know for Q3 of last year, all my Blue Cross patients who were over 65 years of age that had a knee arthroscopy, I want to know the reimbursement, the write-offs, and get down to the really granular level. It's very difficult to do in the standard reporting functions of the MISs. So that's why it's key to have some a good reporting tool that can overlay if you have multiple systems. There's software out there that no matter what you're using, whether if you're using a Source Medical product, an HST product, an AMCI product, it can pull data from any one of those. Aside from the ad hoc reporting, should be able to provide you with a dashboard, which will allow management and users of the software to be able to, at any time, have real-time data on specific revenue cycle metrics. What's great about the particular software we use, and many of them out there, is that the parameters around the metrics can be defined specific to your ASC. So, for example, days outstanding, which we will cover much more deeply in a future webinar. But if you think about days outstanding or days in AR, typically, you want to shoot for 30 for most facilities, but 30 may not be a metric that or a standard that you're striving for if you're a single specialty facility with a high Medicare population. So, your standard probably you want to have your ARDs between 18 and 22, and maybe if you're between 22 and 26, you're kind of middle of the road, and if you're over 26, then you're in trouble. So picture green, yellow, and red and kind of a speedometer of the car. We can set up those parameters specific to each one of your respective facilities. So once these three questions, you've addressed these three questions and have definitive answers to these, affirmative answers to these questions, then and only then should you start to look at how we can staff the business office. And going back to my previous story of when I started at Regent, when I came aboard and people were asking me the question, and I was asking staff at Regent the question, how do we staff the business office? I didn't get any clear answers, and so I did some research on it and found that there wasn't really any definitive data out there that existed in the ASC community as it exists out in the hospital industry and the physician industry. So what I did was, since we had a bunch of ASCs, I decided just to conduct our own data, start pulling all of our centers and seeing where we stood, and start conducting a survey regularly to see how we progress and create our own metrics. So back in 2010, I decided to pull the data. We pulled it from June of 2009 to May 2010. And you can see the 14 facilities that we have, and the results came back, and you can see furthest to the left to the furthest to the right, those to the left will be the lower FTEs per 1,000 cases. So it's important to note here that the lower the number, obviously, the better, the more efficient they were. So 1.14 for ASC represents they had 1.1 staff per every 1,000 cases they did. They did roughly 40, 200 cases, so they almost had 5 FTEs here in this case. We averaged across all of our facilities 1.85 FTEs per 1,000 cases. And as you can see, what we looked at was, and we noticed that, at least in this data set, those facilities that had lower acuity or lower, not lower acuity, lower volume, were less efficient for the most part. You see surgery center number 4 was one of the kind of exception to the rule, but for the most part, the last 4 were the lower volume centers, and they were least efficient. And, we started thinking about this, and we hypothesized that, more than likely this was due to the fact that they have low volume, but still they have essential business office functions that they have to fill. For example, they're going to always have to have a receptionist to greet the patients, more than likely a business office manager or business office supervisor, and probably one other person that's scheduling insurance verification. So it's a minimum of 3 people. And so those facilities that don't have that much volume, you see that these essential functions that they need to require in their business office staff, they may not be as fully utilized as someone in a much busier center, but it's not as if they could cut that person in half or anything. So they still need to utilize those 3 FTEs. However, they're more than likely not fully utilized as they are in the higher volume centers. So We conducted the business office study again in 2013. As you can see, we had 4 more facilities take part in this survey. And for the first time, we had a facility break the 1 FTE per 1,000 cases. You can see the facility all the way to the left is a 0.92, and we had one that was very close at 1.12. I will say the facility that's all the way to the left, although we don't have any single specialty facilities, all our facilities are multi-specialty. The facility that we have to the left is the closest we have to a single specialty. They do primarily endoscopy with some pain as well. So, that accounts for somewhat of their efficiency, but I will say also, not just their lower acuity, but we have a business office manager in this facility who is very active in the business office. So, it's not uncommon to walk in and find her manning the reception desk, or she may be helping with scheduling or any other functions. We also provide the billing and collections for this facility, and so we only have one person doing all the back office functions, so that helps in driving that number down as well. You could see, whereas in our first study in 2010, the same pattern is evident here, where the lower volume centers, for the most part, are less efficient, and again, more than likely due to not being able to split people in half. Still, the essential functions of a business office staff. You can see our the highest that we had was 3.02, which is significantly less than our first study, and our average has come down to 1.76. So in our most recently completed study we conducted in 2015 on 2014 data, you can see again that the same pattern holds true, where for the most part our lower volume centers tend to be less efficient. We do have the one facility, ASC 14, that has a high volume but a high number of business office FTEs. That one actually can be explained by, this was a merger of 2 different facilities. And at the time that we conducted the study, the merger had just taken place. 2 different business office staff members were all combined, and the administrator at the time knew that she would have to be, and has since, decreased the business office staff due to an overlapping of functions, but at the time she hadn't done that yet. So, I fully expect when we conduct this study again, this number will go down. So again, the same pattern holds true, but the one interesting note to make on this is that you could see our region average has gone down to 1.52. So in the period from 2010 to 2014, we were able to reduce our average almost 0.3 FTEs. And 0.3 FTEs doesn't sound like that much, but it's really 0.3 FTEs per 1,000 cases. So if you're a center that's doing 5,000 cases a year, this is actually 0.3 times 5, which is 1.5 FTEs. So taking into account salary and benefits, we just saved about $100,000 per year with that decrease. Okay. The decrease that we had from the 1.8 in 2010 to the 1.5 in 2014 was driven primarily by addressing the 3 questions we spoke about in the beginning of the webinar, and specifically that advanced technology such as the insurance verification piece, where we're able to now just not have to spend minutes, even hours on the phone with the insurance companies trying to get benefits, and we're able to do that in seconds now. So that takes us to the end of the webinar. We will now open this segment up to any questions and or comments.
Okay, Mike, thank you very much for walking us through those slides. We do have questions coming in from the WebEx Q&A portion, so let me be the spokesperson here to put these in play. First question: the previous center I worked for outsourced their RCM, but my current board is not the biggest fan of outsourcing our billing and collections. Do you have any suggestions on how to convince them of the merits of outsourcing as an option as we focus on being more efficient?
Sure. And that's a great question. I think I'd start off by saying, every facility is different, and it really would depend on your specific situation. One tool that might be very helpful to you is to conduct a business office audit, which will determine your deficiencies in your revenue cycle management. So, if you have the background, take a look at the contracts that you have in place and make sure that you're collecting everything that you're entitled to collect. If you don't have that business office acumen or the revenue cycle acumen, look to outside firms to be able to conduct a business office audit. There's many firms, including Regent Revenue Cycle, that offer free business office free business office audits, and this will allow you to really look and determine if there are deficiencies within your revenue cycle.
Thank you, Mike. Next question. Are all of these facilities on EMR? If so, how do you think not having an EMR would affect your staffing ratios?
Not all the facilities that we have at Regent are on EMRs. In fact, very few are. We determined early on that the investment that was needed into an EMR there was no return on investment. There was not an increase in efficiency, and at the time, the costs were in the six figures. Now, that was admittedly several years ago. Nowadays, I know several large companies in the ASC arena are developing their EMR, so we will wait to see what kind of efficiencies that drives. So, as far as not having an EMR would affect your staffing ratios, I would say no. I think the more important piece driving that efficiency is the technology and really making sure that you have the appropriate staff in place.
Next question, Mike. Is the office accountant counted in this?
The office accountant is not accounted for in this. I will, and I probably should have addressed this earlier, what exactly do I mean by a business office staff and what was included? So who's included in this metric is your business office manager, your front office staff, including your receptionist, your insurance verifier, scheduler, medical records clerk, and then your back office staff. And that's your payment posters, your billers, and your follow-up personnel. And I think it'd probably be easier just to tell you who's not included. Not included in this would be the administration or the administrator, any clinical staff, and your materials managers. And I guess office accountant, if you have one.
Mike, next question. Our hospital partner manages our billing and collections, but I don't feel like they're doing a great job. Any suggestions?
Yeah, this is an interesting question. We find it often where you have a hospital partner, and since they do their own billing and collections, they feel they can do the billing and collections for the ASC. Obviously, this is going to be a general statement, but what we have found is that hospitals typically do not do a good job doing the billing and collections for the ASC. And a couple of reasons that we found. One is that usually the hospital is much larger than the ASC, so much of their billing and collection efforts are going to be spent toward the higher entity, and the ASC is usually, as far as list of priorities, further down the list. Second of all, although there are many similarities in the revenue cycle management of each of the hospital and an ASC, there's many differences in ASC billing. And if you do not know ASC-specific billing, you could be leaving a lot of money on the table. So, again, I would tell you, I recommend that you look at your revenue cycle metrics and compare them to industry standards. And again, I'll tell you, if you can get a business office conducted, if you can do it personally or if you can have it done by an outside firm, do that. And then you can compare those, the results to industry benchmarks. And if you see deficiencies there, that may be an opportunity to bring up to the board.
Mike, next question. Are these for business offices that are performing all business office functions, scheduling, coding, collections, billing, insurance verification, reception, et cetera?
Good question. It's a combination. We have facilities that we perform the billing and collections for, including the survey, and we have facilities that perform billing and collections in-house. I will tell you, referring back to the slide that had our most recent results, 4 out of the top 5 of the facilities that were most efficient toward the left were centers that Regent performed the billing and collections for.
Thank you, Mike. I've got 2 more questions in the queue. Next question, how many staff specifically work on billing, charges, payments, AR, appeals? This would not include scheduling or front desk reception work.
Yep. So, as I mentioned before, here at Regent, if we're doing the billing and collections, almost exclusively we have one person working on the account, and that person does the billing, charge entry, the payment posting, the insurance follow-up, and the patient follow-up. There's only one center we perform billing and collections for that we have more than one person working the account, and this is a fairly large center. We're looking at $22 million in yearly revenue. They have 8 ORs, 4 procedure rooms, so an enormous operation, and we actually have 3 business office staff handling that facility. But most oftentimes, 99 out of 100 times, it's a one-to-one relationship.
All right, Mike, and last question. Do you have recommendations for those centers who do not outsource staffing?
Sure. You know, it's a couple different things. One, you want to look at, make sure that your staff are cross-trained. You know, what we find with facilities that have their billing or RCM insourced is that the challenges they face is if especially in smaller centers, if they have a person that's going to be out for an extended period of time, those that are planned are easier, but you know, a sudden illness or something could leave the facility cash-strapped very quickly. So make sure you have backup and staff are cross-trained. Utilize technology. You know, this technology is not only for billing collections companies, but can be for individual facilities. And just make sure that you have the appropriate policies and procedures in place to make sure that you drive efficiency.
Thank you, Mike. At this time, I do not see any further questions, and we're right about 38 minutes for everybody on the phone. I think we'll cut it here. Thank you very much to all participants who've joined us today. Mike, thank you very much as well. Again, this concludes the first of 3 sessions, and we look forward to reconvening with everybody approximately 2 weeks from now on session number 2. Thank you very much.